This is quite a big brief to deliver in 20 minutes to cover off sepsis and AMR and severe infection, but hopefully we'll manage. That's not such a good start. Okay, so my position, as it says there, is I'm the founder and Chief Executive Officer of the UK Sepsis Trust. I'm one of the vice presidents. That sounds grand. There are 5 of us of the Global Sepsis Alliance, and I work with the WHO, UKHSA, DHSC, and other agencies to try to play our part in improving outcomes from sepsis. Now, this, as you all know, is a highly prevalent problem. This is just for comparison. This is just for context. So COVID-19, I'm an intensivist, it was horrible, and I'm sure all of you know it was horrible. But in the 3 years running up to February 2023, according to Johns Hopkins University, COVID-19 directly claimed 6.8 million lives around the world in 3 short years. A huge number of lives claimed, and that pales into insignificance when we consider the indirect lives lost to COVID-19. But sepsis is estimated by the Institute for Health Metrics and Evaluation to claim 11 million lives around the world every year, with almost half of those lives lost being children under 5 in resource-poor countries. So it's astonishingly prevalent. This is almost certainly an underestimate. Cancer diagnosis, particularly in resource-poor environments, is very under-recorded, but the quanta are huge. The actual numbers don't really matter. These are all estimates. The quanta are enormous. Sepsis is estimated by WHO to account for 1 in 5 lives lost around the world. Now, this is also within a 20-mile radius of this building. This is Villa Park, the home of Aston Villa Football Club. And again, it gives us context. Because breast cancer around the UK every year claims around 11,000 lives, bowel cancer rather more around 16,000. Sepsis is estimated by that same group, the Institute for Health Metrics Evaluation in North America, to claim 48,500 lives across the UK every year. We cannot, of course, prevent all of those lives lost. And many of these conditions coexist. An obvious example being someone who's receiving chemotherapy for breast cancer, develops neutropenic sepsis, and dies as a consequence of that. Now, of course, without breast cancer, they probably wouldn't have had sepsis. So are we being disingenuous in overcounting this? Surely this is a consequence of dying of another condition. Well, I've noticed Paul's in the room and he might choose to challenge me, but I think that the goalposts for intensive care admission have moved immeasurably over the 20 or so years since I've been a consultant. 20 years ago, we wouldn't have dreamed of admitting someone being palliated for breast cancer to our intensive care units. Now it's pretty routine. Yes, we might not offer multi-organ support, but we'll certainly offer vasopressors, we'll certainly offer non-invasive ventilation to support them through that episode so that they can get home to a valuable few weeks or months with their loved ones and tick something else off their bucket list. So I think it is worth double counting. It is worth the granularity of information. Sorry, that's Italian, because I gave this talk in Venice a couple of weeks ago. So 48,500 in the UK. Italy has pretty much the same population, so I don't know why they estimated a higher death toll in Italy. And in Italy, sepsis doesn't have an S on the end. Now, who gets sepsis? So it is true. And if you listen to the wonderful Mervyn Singer talking, he will tell you that sepsis is predominantly a condition of the old and frail, and that is true. It is far more likely we develop sepsis as we age or in the very early months of our lives than in the prime of our lives. But of course, our population isn't structured linearly. There are far more people of our age in the country than there are neonates or there are octogenarians and nonagenarians. So in terms of who we actually see, the spread is much more uniform. Some of the best data in the world at the moment come out of New York State because they have a legislated and resourced statewide initiative. Now, New York State has 21 million people living in it. This is not a small piece of work. In 2019, almost half of adults admitted to New York State's hospitals with sepsis were working-age adults. Among children, just over half were school-age children compared with preschool children. So again, yes, it is true that the incidence of sepsis is much higher in an octogenarian than in any of us in this room. But because there are more of us, we see as many working-age people as we do retirement-age people. But I promised to talk about severe infection as well, because we have to remember that sepsis is a bit of an artificial construct. Yes, the concept is, of course, robust, that this is a dysregulated host response that precipitates organ dysfunction. Of course that's robust. But the international consensus definition requires the use of a change in the SOFA score, which is fine in some cohorts, but it's a bit illogical to apply the same thresholds for the same parameters to people who are 18 and healthy as we do to people who are 88 and unhealthy. So it is a slight artificial construct, and what a patient in their home wants to know is not, do I have sepsis, but do I need urgent hospital assessment and urgent parenteral antimicrobials? Of course that's what they want to know. They're not interested in diagnosis of sepsis. So we have to look at serious infection. We have to look at the conditions that precipitate sepsis commonly. And in high-income countries like ours, it is these four. You can read them for yourselves, and you know all of this. But in terms of the quanta, these are vast. We did a head count of the hospital episode statistics codes for England during the year 2017. And we excluded people who survived and spent fewer than 3 days in hospital because we tried to get rid of some of the jargon data. And we counted all patients who had one of those codes within their first 3 diagnoses at discharge. And it was a huge, huge number. Almost 40% of people admitted to hospital were either had their admission caused by one of those infections or complicated by one of those infections, according to coded data, which are not that robust. But the quanta sort of get rid of some of the potential inaccuracies. So why am I showing you this? Well, I'm showing you this because we use antibiotics in these people. Remember, these are people with peritonitis, they're people with cellulitis, they're people with urinary tract infection, they're people with pneumonia, bad enough to be in hospital. They're going to receive antibiotics. They're probably going to receive exactly the same antibiotics as if they had a technical diagnosis of sepsis. So antimicrobial resistance is not because of sepsis, not because of any individual infection that we're trying to treat, not just because of injudicious use in animals as well as humans, but because we want to stop people dying. It's a natural evolutionary consequence of our desire to stop humans coming to harm from infection. Now, the World Health Organization and other entities have begun to take sepsis very seriously. We were just discussing with Jocelyn, we've got a number of meetings with DHSC, senior figures within the current NHSE coming up to work out how we can improve sepsis practice once again. But when we got the WHO resolution adopted, we wrote this opinion piece in one of the journals, and we asked the former CMO, Sir Liam Donaldson, to write a forward. And he said these really important clinical issues, some of them life and death, exist in this backwater, but that the public and political space is where sepsis needs to be in order for things to change. Now, very briefly, I will describe one of the functions of our small charity, and it is raising public awareness. This is also within a 20-mile radius. It's one of our train stations in Birmingham. And we don't pay for any of this stuff. This is just about relationships. This is not paid for advertising that we see on the sides of our shouty yellow vans. This is simply approved messaging, approved by the then Public Health England, now UKHSA, that allowed us to put this messaging on our ambulances across the country. Similarly, we don't pay for large format advertising in city centres. We don't pay for any of the relationships we form. We simply say, can you use your existing dissemination mechanisms to get potentially life-saving messaging out to as many people as you can. We don't pay to play storylines in soap operas. This was Holby City, but we work with EastEnders, Hollyoaks, Call the Midwife, Coronation Street. This is just forming relationships. This is not paid for advertising. But what we have learned, the intelligence we have, is that most of our public know about sepsis now. 96% have heard of the word sepsis, 91% know it's bad and it's a medical emergency. But can anyone remember the symptoms? Absolutely not. So what we're going to do, we're just about to launch a Class 1 medical device that will sit within our online services, signposted to by a good old-fashioned QR code, and that Class 1 medical device will use the existing approved symptoms list, those we previously agreed with PHE. It can iterate over time, and it can guide people to the right way to access healthcare. It can recommend that they go straight to hospital. And I think we have to recognise that we do have a problem before we come to some solutions. We've seen several reports over the last 18 months suggesting that we have an issue. The Health Services Journal was one of the first. looking at 31 prevention of future death reports and finding common themes. The Parliamentary and Health Service Ombudsman was the second, a 10-year follow-up to their original report, their first ever in-depth report on sepsis. They found exactly the same themes a decade later. Now imagine if you were Melissa and you had been campaigning with us for a decade and you found that exactly the same mistakes were being made. The National Child Mortality Database, and as a in interest of transparency, I was a co-author of this report, but we found that where children had died with or of infection, in 40% of cases there were modifiable factors that might have changed the outcome. Not would have changed the outcome, but might have changed the outcome. So even in children, we're letting them down. And we will continue to work with people affected by sepsis. So Melissa obviously is an absolutely brilliant ambassador for us, but we're not short of ambassadors because there are so many people who lose loved ones to sepsis or who survive sepsis with adverse outcomes. And it's often because they haven't been able to navigate through the healthcare system well. Now, Craig's the exception, or one of the exceptions. Now, Lord McKinley lost his limbs to sepsis. He was treated brilliantly. He could very easily have died. His wife phoned me up within 6 hours of his hospital admission and said, they're doing this, 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 and this. Is there anything else they should be doing? All I had to add was, it sounds a bit like Group A strep, which it did turn out to be. They might want to think about intravenous immunoglobulin. That's all I added. Everything else they had done brilliantly. I don't think any of us in this room could have saved Craig's limbs. But he, despite the fact that he was treated very well, now has very visible sequelae of sepsis. And we have to remember, and if anyone would like to hear more about the service we offer to your patients who might have survived sepsis or been bereaved by sepsis, you can find Oliver later. Oliver, I know you're a delegate, but please wave your hand if you can talk about your support services. You can find Oliver later because Oliver's the lead support nurse within our charity. So many people have invisible after effects, and we need to navigate our way through that. This is an inquest recently. This was William Hughes, the 22-year-old who died at Homerton Hospital. This is all in the public domain. And his own mum, who is a consultant paediatrician at the same hospital, said he had meningococcal sepsis. Yet clearly, and I can say this now because the coroner ruled this, there were deficiencies in his care. The coroner could not say whether or not those deficiencies might have contributed to his death, but he was not treated well within that hospital. So what are we going to do about it? We have now a stable landscape in the space of sepsis, at least for a period of time, and at least in adults in the acute sector in terms of our strategies. Long before the Academy of Medical Royal Colleges were asked to look at sepsis and look at timing of antimicrobials, some 3 years before, the International Academic Guidelines Group looked at sepsis and updated their guidance. Now, the first thing to say is that my organisation, University Hospitals Birmingham, still has QuickSOFA in their screening tool for sepsis. They should not. I'm not involved in the process of care within my own organisation. But the recommendation was against the use of QSOFA in organisations already using aggregate track and trigger warning scores or SIRS criteria to recognise sepsis. And remember, all of these are not sepsis definitions. All of these are screening prompts. In whom shall I think of sepsis? So obviously we have news too, and that now forms the basis in the acute care sector of our screening strategy, our screening prompt for people with suspected sepsis. The other thing that the Surviving Sepsis campaign said is, yes, we know there's reasonable evidence for people with septic shock that antibiotics need to be given early rather than late, but there's much less good evidence outside septic shock. So they adopted a very pragmatic approach to this, one that I think could have easily been implemented in this country. That we take a patient with suspected sepsis and we ask ourselves two questions, two simple questions. Number one, do they have shock? If they have shock, we're going to treat them within 1 hour with antimicrobials. If they do not have shock, we ask ourselves a second question. How sure am I that this is sepsis? If we're fairly confident, we're going to give antimicrobials within 1 hour. But if it's one of those many grey area patients who could have a range of differential diagnoses, we allow a more generous time window of 3 hours in which to administer antimicrobials. So that's the international guidance. And of course, we chose to ignore that in the UK. So NICE published updates just over a year ago now, to their NG51 national guideline. And you will have seen this. The guidance changes only affect people over 16 years of age in 3 clinical environments: pre-hospital services, acute mental health settings, and acute hospitals. For patients outside of those environments, nothing has changed. We're still using the old red flag sepsis criteria that we sort of conjured up slightly arbitrarily with NHS England and the Royal Colleges back in 2015. But for people in the acute sector who are adult, we now have a news-based approach. And it essentially looks like this. As NICE tend to, they came to us and said, can you help to operationalize the guideline with some clinical tools? And we said, of course. And we now have 2 thresholds for News 2. So if the News 2 is 7 or above, we're going to treat those patients as red flag sepsis using old terminology, treat them urgently with antimicrobials within an hour. If it's 5 or 6, then we're going to have that more generous time window of 3 hours in which to make a prescribing decision, which is great in theory and is largely evidence-based, albeit the inflection point for News 2 is actually at 4, but they felt that that would generate too large a workload, so we chose 5 instead. In my hospital, I work in intensive care, as you know. My nurses send a full set of bloods for all of our patients at 6 o'clock in the morning. I turn up at 8 o'clock in the morning, have handover, start my ward round at about 8:45, 9 o'clock. Bloods aren't back. Of course they're not back. I don't have anything back. So I think we have to think about this pragmatically. Do we have more information at 3 hours than we have at 1 hour? In my hospital, we might have a chest x-ray, we might have a bedside ultrasound, but we're certainly not going to have much else. We will have a blood gas, of course. If we're going to have more information at 3 hours, then let's implement this, providing we can mitigate against very long delays. Because if you think about it, if you're treating someone urgently within 1 hour, you know it's your job as a junior health professional. I'm not suggesting any of you junior. But if you allow a more generous time window of 3 hours, think about what happens. That patient sitting in the emergency department, they're not a priority. A bed becomes available, they're moved out, they're not going to get seen again by a prescriber until the post-take ward round. So we've got to mitigate against very long delays in people who are triaged to a more generous time period. The Sepsis 6 is something that we developed some time ago. I am coming on to AMR, and I know we're slightly short of time. It now looks like this. So if people are using 3 in, 3 out, that no longer applies. If people are using Buffalo, that incorrectly spelled aid memoir to the Sepsis 6, that no longer works either. Because it's not 3 things in and 3 things out, it's 6 actions to deliver. And this is based upon NICE NG51, it's supported by NICE, it's signposted to from their website, and these are the tools against which NHS Resolution and the CQC monitor the way people are addressing sepsis. Important to know that we know there are significant delays getting people to hospital, getting significant delays in offloading people once they do get to hospital. So GPs and ambulances for people of all ages, I've just screenshotted one of these, but the language is the same for every age group, need to think about how they can safely deliver antimicrobials to people with suspected sepsis if the transit time is going to be over 1 hour. AMR, just to finish. We achieved great things in England between 2016 and 2019. Some of you will have been involved in the sequin for sepsis. These were unpublished, which is very disappointing because New York State get all the glory, but our performance was just as good as New York State's. We went from a baseline of 32% of patients getting antibiotics within 1 hour to a peak of 80% in Q4 of 2019. So huge process improvements. This was not cause and effect because these were simply observational studies that happened during that same time. But NCPOD, the government's own database, and Sir Brian Jarman's report in 2018 seemed to suggest that mortality during that time period was reducing. So again, not cause and effect, but it's interesting. New York State, which did match process to outcome, found exactly the same mortality improvements, almost to the decimal point. But our friend Mervyn and others were saying, well, we're now using antimicrobials like Smarties in emergency departments, and that's bad. And of course that is bad. And the headline in the Lancet was, the sepsis campaign has doubled antibiotic use in emergency departments. Well, has it? Well, yes. These are data from the Royal Pharmaceutical Society, the data on which Mervyn and colleagues wrote their letter to the Lancet and based their allegation. And it did show that from a convenient time point before any sepsis campaign, antibiotic use did double. But we'll forgive the artistic license because it was a good headline. But I think what we're much more interested in, surely, is total hospital use of antibiotics, including in the emergency department, and it barely changed. Yes, a 1% increase is worse than a 0% increase or a reduction, but it's certainly not a doubling. So I would argue that the data from the Royal Pharmaceutical Society suggests that sepsis campaigning, if it were such, incentivizes early antimicrobials without increasing total antimicrobial delivery in hospitals. And we've got similar data which are in the public domain from Ireland. So just to finish, I think we all accept that we're not doing very well at the moment. We all accept that it's slightly artificial to have a one-size-fits-all definition. We all accept that we don't have great evidence that everybody needs antibiotics within the first hour, and in some cases, early antibiotics might cause harm. But we've got to change the policy landscape. We've got to grow up with respect to sepsis. My mum had breast cancer last year, and within 2 weeks of her diagnosis, they knew exactly what her genetics were regarding her cancer. They knew exactly what type of interventional therapy she needed, exactly the timing of surgery. They knew precision medicine. We are so far from that in the sphere of sepsis. But to change that, we've got to change not only science, but also policy. So this group, of which I'm co-chair, is now calling for, at a policy level, to bring all of the aspects of infection management together. So prevention, stewardship, sepsis management, and surveillance. Bring them all together under one policy umbrella. We have an NHS action plan. We don't know what's going to happen to that. Probably nothing over the next 2 years as the NHS contracts and eventually subsides. But what we've got to do is to grow up with respect to sepsis. Why should it be the poor relation of breast cancer? Why should it be the poor relation of heart attack, of stroke, of cancer, of other conditions where there are incentives and tariffs to encourage better action? This is the stroke best practice tariff. There is a 64% increase in the amount of money your hospital gets if it treats stroke well, per capita. We don't have that for sepsis. Why not? We need to begin to grow up. We need to begin to prioritize this and allow us, you, to invest in improved outcomes. And that is going to be around better diagnostics, around better integration of novel and rapid diagnostics into clinical systems in order to give us the prescribing and diagnosing information we need in a much more convenient timescale. It is going to be around recognizing phenotype. These are now old data. This came out 7 years ago now, 6 years ago now, but there were data coming out around phenotypes, particularly out of the east coast of North America, for some years. Not everybody with sepsis looks the same. Craig probably can't change anything. Martha could easily have been saved because she had a much more insidious development of her condition and opportunities to rescue were not taken. Is it all about AI? Well, there are people claiming this. Cause for celebration. Johns Hopkins again, prestigious university. The AI was accurate nearly 40% of the time. So it's not good enough yet. But what we definitely need are big interoperable data sets. We need sepsis registries. We need pattern recognition of large patient-level data so that we can begin to understand this condition a lot better. So as you can see there, penultimate slide, there is, in the academic literature, a word of caution around AI, but it will be a part of the future. It's not going to be on its own. It's going to be around the understanding of the condition, the understanding of the biology, the understanding of phenotypes and endotypes, and truly moving toward precision medicine. And I think it will probably happen over the coming years. Thank you very much, and sorry for running over.